Assalamu alaikum. I'm Dr. Waqar Ahmed Siddiqui. I'm Associate Professor in Department of Pharmacology at CMS Lahore Medical and Dental College. So, Limbs for Life is a program that is launched in collaboration with Frozen Laboratories. We are at Module 6. We'll talk about neuropathy in detail, and the topic is neuropathy, a double-edged sword. Objective of this program definitely save the limbs because the limbs are life. So before we go on to neuropathy, let's go into some basic structures of neurons. And you are quite familiar with the structure of neurons. If you go in a little bit detail of it, you see these are the dendrites collecting all the information. And we have the soma, nucleus, and the axon and the nerve axon terminals. So all this, they collect the nerve signals and they transmit it, right? So any nerve damage so lead to distort signals, and definitely if the signal is distorted, it will lead to creating new signals that are not normal. So when the thing is not more normal, what will happen? Non-painful signals will become a painful signal, right? So problem can cause painful symptoms, which can range from mild to severe, depending upon how the nerve is damaged, and plus which senses are involved, that nerves involving that senses like touch, temperature, movement, pressure. So and these things can be get disturbed when a neuron gets damaged. So symptoms of neuropathic pain. Let's just go through some basic definitions before we go on to the main chapter. Uh, Neuropathic means we have some negative symptoms and we have some positive symptoms. When we talk about negative symptoms, there is reduced perception of either non-painful, painful stimulus or heat. So hypoesthesia is reduced perception of non-painful stimuli. Hypoesthesia, reduced perception of hypoalgesia, is the reduced perception of painful stimuli. And thermohypoesthesia is reduced perception of heat. So when you talk about positive symptoms, right? So positive symptoms, like something is added to his symptoms. What is added to his symptom? Let's first talk about paresthesia. So paresthesias are spontaneous, abnormal, usually non-peripheral sensations that is experienced by the pain person. That may be due to lesion of both central or peripheral nervous system. In paresthesia, what usually happens is patient feels burning, tingling sensation, pins a needle in the hand, right? So these are the paresthesias. Paroxysmal pain, with the name paroxysmal, that it comes and goes, it's intermittent, it's a sharp shooting pain. So paroxysmal extreme pain disorder, it can be defined as is a form of peripheral neuropathic pain characterized by skin redness, skin warmth, flushing, and attacks of severe pain in various parts of the body. Usually, lower limbs are involved. Now, this pain can remain for a few seconds. It's a short duration of pain, but it's extremely short shooting pain, and it comes and goes. Superficial pain, continuous burning sensation on the superficial of the skin, like the skin, the nociceptors that are present on the skin, they get activated, and a well sharp, well defined, and well located pain is felt by the patient, right? So these are usually minor wounds or first degree burns. They come under superficial pain, but the point is that they are well defined and well located. Patient can locate that pain. Right. Now, this stimulus-induced pain, when we talk about this pain stimulus, these were the spontaneous pains. So, allodynia. So, allodynia is defined as a type of neuropathic pain, right? When people with this problem, they're extremely sensitive to touch, right? And things that usually do not cause pain, right? Like brushing of hair and wearing of clothes, the cold temperature, right? So these are the moving stimulus. They are usually non-painful. So this, what if the patient experience that, this comes under allodynia, right? So hyperalgesia. So hyperalgesia, pain induced by typically non-painful stimulus, but stimulus is static, right? So in when if we talk about hyperalgesia, even if the stimulus is non-painful, like if you like give small pen or not a sharp needle on a surface, if the contact is continuous, patient will feel extreme pains, more pain than expected. This is the hyperalgesia. Summation pain, ठीक है, summation pain, increased amount of pain due to a typical non-painful repetitive stimulus, right? This can be of spatial or can be temporal summation. Both can be classified. So if they increase the area of evoked stimulus, like they increase the area on which the stimulus is given to the patient, okay, so the patient experiences more pain. So increasing the area, more pain. A temporal stimulation, repeated and equal intensity noxious stimulus, if applied at a specific frequency, causes increased pain that is experienced by the patient, right? So same stimulus, same frequency, applied repeatedly, and is a noxious stimulus, patient will experience more pain, right? So these are the few definitions of you have understood. All right. So here we'll talk about distribution of neuropathic pain, right? So it can be central or it can be peripheral. So when we talk about the peripheral neuropathic pains, there are a few examples, like for example, trigeminal neuralgia. So with the name trigeminal neuralgia means trigeminal nerve is involved. Neuralgia means pain, nerve pain. So it happens in the territory of the trigeminal, that is facial, mintraural, where the trigeminal nerve territory is. And we talk about pain, it's a very sharp shooting pain, continuous pain, burning pain the patient experiences is very troublesome. Post-herpetic neuralgia, with the name post-herpes, it happens after the herpes infection, shingles, varicella zoster virus, the culprit of it. So basically, it involves dermatome, one or more dermatome, and the dermatome sply, the dermatome where it splies on that part, the vesicle repair, and they become very painful. Right? This pain can last for weeks to months, and maybe go up to in a year. It's a very initially sharp pain, burning pain, and it's kind of unrelenting pain that the patient experiences. Right? So if it's in the territory of trigeminal, so same the area of trigeminal nerve is involved. Peripheral nerve injury pain. So a traumatic nerve damage. So it happens after a traumatic nerve damage and is typically distal to the site of injury. If it happens after surgery, if it happens after trauma or compression. So it is a very unrelenting pain, sharp pain, burning pain, tingling, can lead to total loss of sensation on the affected part of the nerve damage, right? So it can present in all these ways. Post amputation pain, with the name showing post amputation in the missing body part, the residual limb. So it also called stump pain, phantom limb pain, phantom limb sensation. All are classified as post amputation pain. Painful polyneuropathy, mostly affected the peripheral nerves. Again, same, just like paresthesias, patient will feel pain like that. Most common in hands and feet. It is more commonly like tingling, burning sensation, and this usually leads to weakness, numbness, as already told in hands and feet, right? So pulling in different multiple nerves are involved. So both hand, both feet, um, right? Okay. So painful radiculopathy. Now in this painful radiculopathy, injury or damage to the nerve root, especially in the area where it leaves, and that nerve root, wherever it supplies, patient feels pain in that part of the nerve supply, right? So the innervation territory of the affected nerve root is affected, and especially it happens where the especially injury to the nerve roots, if it happens, so patient experience feel on the territory. Right. So let's move on to the central neuropathic pain. So neuropathic pain associated with spinal cord injury. It can happen at or below the level of spinal cord. Post-stroke pain can be contralateral and can be unilateral depending on the site of infarct. Ipsilateral on the side of the face, on the contralateral again involving the site of infarct. Central neuropathic pain associated with multiple sclerosis, so it is a combined of both. But you can say that in multiple sclerosis it affects nerves, right? And patient feels acute or paroxysmal muscle pain, and this pain can be in the form of spasms. So this is how the neuropathic pain associated with multiple sclerosis feels like. Right. Right. So moving on to typical nociceptive pain. So in typical and nociceptive pain, what happens that there's a preserved sensation above the neurological level of injury, right? Located usually in the musculoskeletal structure. The pain may be dull, aching, or it may be sharp, and usually is aggravated by the movement, right? So in that typical type of pain, this typical nociceptive pain usually responds to non-steroidal anti-inflammatory drugs, and definitely opioids are there, more powerful pain relievers. So opioids may also be helpful in that pain. And this pain is usually intermittent; it comes and goes, right? So typical below level neuropathic pain. So this pain is extending more than 3 dermatomes below the level of neurological injury. Okay? Onset with 1 year post spinal cord injury, hot, burning, tickling, prickling, pin-like sensations patient feel. It may be sharp shooting, and electric shock on quality. Okay? So these usually pains do not respond to non-steroid and anti-inflammatory drug, and they are often associated with allodynia, just like a non-noxious painful moving stimulus, brushing of hair and changing the clothes. This the allodynia is associated with that. Hypo or hyperalgesia may be a part of it, and usually in non-steroidals do not respond that well, and this pain is constant. Unclear type of a pain, it can be located below the level of neurological injury, onset 2 years post spinal cord injury, may be described as cramping, sharp, sometimes it gets aggravated by movement, some tactile sensation in response to increasing mechanical stimulus in the painful area. So it's intermittent, right? And muscle spasm, visceral injury is one of the example of unclear type of pains, and usually it requires to be determined. It needs to be investigated, right? So here we are going to differentiate between pain due to neuropathy and pain due to ischemia. So pain due to ischemia. Let's talk about the pain due to ischemia first. So pain due to ischemia is a persistent pain, worsen on elevation, and relieved by dependency, right? Because during elevation of ischemia, the lack of blood supply to that specific area leads to pain. Pain in the calf and is usually is relieved by rest and is aggravated by exercise. And when it's aggravated by exercise, we call it claudication, intermittent claudication, because when you do rest, the pain goes away. However, claudication is often absent in ischemia because of concurrent neuropathy associated with it, and the distal distribution of arterial disease. So if the arterial disease is very much aggravated, patient may not feel pain. Okay? So when we talk about the neuropathic pain, it's a burning pain with contact discomfort, usually extremities, feet and lower legs. It may also involve thigh, and if it may have involving hands, it may involve the arms. Right? It's a sharp shooting pain and lighting pain like electric shocks lasting for a few seconds. It can also happen like that. Usually these are fine tingling burning sensation, is usually it is like that, but it can move, patient can feel like electric shocks and very sharp shooting pain. Pain is usually relieved by cold, and if you talk about This pain usually when patients sleep, they usually take their feet out of their blanket because they feel comfortable by that. Pain worsens during the period of rest because if they are working, they are not feeling that pain, and as soon as they do rest, the amount of pain felt is aggravated and they feel more. Unilateral burning pain in the leg with muscle wasting, it suggests focal neuropathy. Commonly, femoral neuropathy is there, so it can present like that. If it's unilateral, it's usually a focal neuropathy, right? So this is how you can differentiate between pain of neuropathy and pain of ischemia. Right. Now, how to assess the pulse of the patient, because in an arterial disease, in extreme diabetes, there is the arteries are involved, the narrowing of the arteries is there, so lead to peripheral artery disease. So how to palpate the dorsalis pedis artery. So when we talk about the dorsalis pedis artery, is palpable on the dorsum of the foot in the first intermetatarsal space, just led through the extended tendon of the big toe, that is extensor hallucis longus. So how this is how you can palpate the dorsalis pedis artery. So when we talk about the posterior tibial artery, so it is a halfway between posterior border of the medial malleolus and the Achilles tendon. So this is how you can palpate both of these arteries to check the pulses of the patient, if they are normal or not. If you're able to, or maybe feeble. So all the qualities of a pulse you have to check. So neurological assessments and its types of motor and autonomic neuropathy and sensory neuropathy. So we'll talk about all these three. So when we talk about the motor neuropathy, the classical sign of a motor neuropathy is high medial longitudinal arch, leading to prominent metatarsal heads and prominent pressure points over the plantar foot. So all this happens because of the motor neuropathy. You can see these changes on the patient's feet. When you talk about autonomic neuropathy, the signs you can see on the patient feet is the dryness of skin, fissuring, distended veins over the dorsum of the foot. So this is how you can differentiate between motor and autonomic neuropathy on the feet of the patient. Just a quick overview of a healthy nerve, and when the blood vessel is diseased, and then they will lead to shriveling of nerve shrivels when the blood vessels disappear. So this is how the blood vessels they get damaged, leading to the changes in the neuron, and definitely the signals are distorted, and patient will feel all types of neuropathic pains that we have already discussed. So sensory neuropathy, when we talk about sensory neuropathy, patient present with no pain, even with significant foot lesions are present, right? So how to check that patient has sensory neuropathy is always this diagnostic test. This is a monofilament test, right? This is a monofilament that can be applied on the foot with a given force of 10 gram. So this is how you can apply monofilament on these different points in order to check sensory neuropathy, right? So polyneuropathy, involving hands and feet, tickling, burning sensation, maybe sharp shooting sensations. And if we talk about motor neuropathy, damage to the single nerve, it can cause individual pain, loss of movement, numbness on specific part of the nerve that is damaged. When we talk about plexopathy, it can be most commonly are the lumbosacral plexopathy or cervical plexopathy. What happens is that there is a disorder or network of nerves leading to pain, muscle weakness, and sensory deficit, right? So when we talk about autonomic neuropathy, so autonomic neuropathy can involve the autonomic nervous system, GIT, BP, blood pressure, temperature control, digestion, sexual functions, bladder functions, all can be disturbed because of the autonomic neuropathy. So sensory loss, You can see in this diagram mild, moderate, severe sensory loss. This is the areas commonly affected by the sensory loss, and patient can present with this type of sensory loss in sensory neuropathy. So here, this is the areas to be looked for. Right. So, so in diabetes mellitus, distal symmetrical polyneuropathy. So when usually it gets developed, it can be of sensory, motor, or autonomic neuropathy. So when we talk about the sensory neuropathy, so patient can sense it, anything. So loss of protecting sensation, patient get repeated minor trauma, or repeated stress on the joints, or on the foot, or on the skin. So these are the consequence of the sensory neuropathy. Eventually can lead to foot ulceration. When we talk about motor neuropathy can lead to foot deformity. Just previously talked about leads to abnormal foot loading. When abnormal foot loading, there's pressure on certain parts of the foot more than the other parts, so that parts get affected. And with that sensory, if the patient has sensory neuropathy as well, so it can lead to foot ulceration. Autonomic neuropathy lead to foot dryness of skin, cracking of the skin, and with that cracking of the skin there's chance of infection, bacteria can grow there, and eventually it can lead to foot ulceration. So once the ulcer is formed, it can get affected, and when the ulcer gets affected, initially it presents with cellulitis, right, and the inflammation of the soft tissue, and that can lead to bacteremia. It needs to be controlled with antibiotics. It will be talked about later in our next modules. And if this infection involves bone, eventually reaches the bone, lead to osteomyelitis. And this stage, if not properly controlled, usually it leads to amputation, right? So definitely vascular risk factors are there. Peripheral vascular disease develops because of the diabetes just previously talked about. Autonomic neuropathy leads to intravenous shunting, abnormal blood flow, so it will lead to poor wound healing. If you have hyperglycemia, you have poor wound healing, inadequate management of the diabetes leads to poor wound healing, and definitely a delayed diagnosis can lead to poor wound healing, and eventually it will lead to amputation that we do not want, and we want to save the limb. Lastly, if we talk about Charcot joints. So in Charcot joint, also known as neuropathic arthropathy, what happens is that with that distal symmetrical polyneuropathy, this abnormal foot loading, plus sensory neuropathy, patient can sense it. So repeated microtrauma to the joints. So when there is repeated microtrauma to the joints, um, there is mal healing. Joint may get affected. Joint, if it gets affected, gets destructed. Plus continuous weight bearing, uncontrolled inflammation because abnormal healing, infection in the joint will lead to rank L activation. So with the rank L activation, there is osteoclastic bone resorption. So bone is getting resorbed, there is inflammation, there all the cytokines are coming there, causing more inflammation, right? So it all these factors will lead to fracture and dislocation within the joint, and it will lead to deformity. And once the deformity is there, and definitely it will lead to amputation, right? So this is the all of the consequences of the distal symmetrical polyneuropathy associated with diabetes mellitus. All right. Okay. Looking in a bit more detail about the Charcot joints neuropathic arthropathy. So, what is actually happening? So, one of the culprit diabetes mellitus, syphilis, leprosy, and pseudogout are the main causes for the Charcot joints. So all these diseases, what is happening is that uh, damage to the proprioceptive and nociceptive neurons in the tracts, it is happening. So with that damage, there is impaired sensorium. makes patient unaware of abnormal stresses placed on the joint. So patient will have minor trauma, major trauma, patient unaware of it, and joint is getting disrupted. And plus damage to the autonomic neurons and crack causes vasomotor changes. So with that, there's decreased perfusion of blood to skin and the bone and the surrounding tissue, lead to poor wound healing. So all of that will lead to minor trauma to the joint in context of impaired protectiveness and the repair mechanisms that are involved that are basically halted or maybe slowed down. So with that, in that stage, if you look in a bit detail, so that will lead to impaired joint protection and abnormal joint movement. So if the patient presenting with increased range of movement of the joints, joint unstable, ligamentous laxity over time, ligaments that get laxed. So this is how the patient will present initially. So joint mounts on inflammatory response. Definitely there is trauma, there will be inflammation. I told you about Rankel, all the inflammatory cytokines, they will jump in and causes local swelling, warmth, and erythema, eventually leading to joint infusion. There will be swelling, all the infusion will be there. Pain, yes, pain will be there. It's a variable response, variable dependent upon degree of denervation. So if the patient has mild degree of denervation, patient may feel some pain and it can be documented. Inflammatory cytokines act on the osteoclast to promote periarticular bone resorption, right? So it will eventually lead to osteopenia. Right? So osteoclastic activity is increased, so it will lead to osteopenia. Now further progressing into the disease, the damage is more than the healing as already told, insult to the joints that accumulates over time. So eventually to joint progress from a minor deformity to a major deformity. So visible joints are subluxation of the joint. Then destruction of the articular cartilage. It will lead to narrowing of the joint space on X-ray. Further progressing, loss of function of the joint, usually in the lower limb because basically they are the weight bearing areas. So patient will have inability to move the joint, interference with the joint movement. So in unstable gait, difficulty in walking, and eventually patient might not be able to walk because of the extreme deformity. So all can be the consequence of this thing, right? So surgical repair, it can be very indicated, but eventually if the joint is too much distracted, then eventually it leads to amputation. Right. So already discussed tools for screening neuropathy. Tuning fork can be used. It can be placed on bony prominences, and eventually we keep on testing the tuning fork test and keep on putting on the bone and ask patient if the patient feels the vibration. We keep on going on the higher level till the patient starts experiencing the vibration associated with the tuning fork. Monofilament test, 10 gram of force is applied on the particular points are already mentioned, um, um, and this is how the neuropathy can be screened. So these are the few questions for you, simple questions. Uh, Already talked about it just for your brainstorming. You can like go through them, and these are very simple questions, nothing that complicated. So thank you so much. Hope this was informative for you. Hope you have learned something from it, and thank you so much.